Okay. Can I start?
Yeah, please.
Okay. Thank you, Jason. Thank you, everybody. And first and foremost, let me welcome you on behalf of Glaucos, Jason and the team to the fourth iStent user meeting. Very pleased actually to see at least a face-to-face meeting. This is a rare occasion now, and every time that we have a chance to be with all our colleagues will be here. Again, I thank you for your time, and I'm looking forward for this meeting. And I truly believe the reason I was actually appointed as moderator because I have so many basic questions being the non-glaucoma on using this particular device. So I'm very pleased that we have a lot of actually experts with us today. We do have a speaker from Singapore, Dr. Leonard Yip, as well as from Sydney, Australia, Dr. Colin Clement with us. Dr. Clement and Dr. Yip will present shortly. And we have our local speaker as well, Prof. Samsia from UKM. Hi, Samsia. And Dr. Zul Helmi from the East Coast, Kuantan, to share their experience with us. I think I'll try to make this as really as a moment of sharing. I'm sure we have all experienced the way that people use it, and we want to know how other users are using it. That's the purpose of user meeting. And any questions, be it actually basic, which usually come from me, or it's actually you think it's a bit advanced, just blur it out. We have expert with us later on. But we're going to actually start first with a few talks to get the ball rolling. And the first one will be Dr. Samsia, Prof. You? Oh, so I should actually just address the webcam. Some people see. Oh, see, that's so cool. So something have to be like this, huh? So does it mean that actually when we talk, we actually no, we don't have, right? Okay, that's fine. Okay, so that's good. Okay, so is the computer ready for Prof. Samsia?
Hold on, let me check with
Not yet. Okay, just give me a cue on that. Before that, can I just a show of hands? How many of the audience today, which is actually mostly make up of the glaucoma specialists, actually implanted mix, have implanted any type of mix, be it iStent or any other? Can I just show of hands? So then we do have many experts then, yeah. So and then I think the one that we want to know is actually later on how do you start, what kind of cases, mistakes that we make that we want to share with you. There's a videos as well that I think Jason and the team have provided us for us to discuss. We have few people in the audience actually have done a few study during their fellowship about this, especially when we have a few types of mix. And even the term mix get confusing, at least to me. Maybe Prof later on actually will highlight this. There is actually a range from mix to MIBS when we have minimal invasive bleb, procedure. So yeah, we got to know that. And the thing is, this is coming. It will not stop. It will keep coming. We have SciPass been revoked, but I think it will make a come later on. We know the few in the market are coming back for superciliary. So for the trabecular meshwork, I think bypassing the trabecular, we have a few in the market. And the first one that we available, at least to me, is actually iStent. I think that's why we have more experience with that. Not many, but we have more experience on using iStent than the rest. And for the others, I think we will actually ask the expert to highlight us today about this. Again, there will be a dynamic on the clinical experience because all our... So I think the topic that we have basically is sharing session. And I think from that sharing session, we will have the experience, at least from the West Coast and the East Coast. And then we have the experience from Singapore and as well in Australia. I think everybody agreed we all have humbling experience. I mean, maybe not the expert like Prof. Samsia, but I do have this humbling experience when we start first. Like I discussed with Dr. Manwa just now. We will show how not to do things. And then things that we share. Okay, so are we okay with the technical?
just for a while.
Not yet? Okay. Do you have a video at least for us to kill time? No. That's right. Okay. I should charge more for that. Okay. I think I begin with actually while we're keeping with the time. I think how I've been grouped to this, and it's never been in my slightest idea that I'm going to use something like this in my practice. But during the fellowship itself, when I did my fellowship in UCLA, what happened is actually we were expected to do the drainage device in the cornea transplant, and I was trained by Ahmad himself, for Ahmad Vaf, and Simon, Dr. Simon. So we were expected to actually know that
Recording in progress.
if you have to do it, then you have to do it. Then Ahmad actually teach. But knowing that there's so many complications can happen with that, and I don't want a headache with that, so that I said, no, I better actually discuss. And we have our colleague, Dr. Aziz, at that time, who actually do a Multino. And then I was actually bombarded with the patient glaucoma with 4 medication and toxicity in the eye, which we don't know what to do, to the extent that we actually give oral Dimox. And that is when it is like a patient who actually have everything on board. On top of that, then you're actually on Dimox. So I don't know what to do at that particular time. That is when then, when we go to a meeting, we heard about mix. And of course, the indication is totally off for that kind of patient. But that was my first cohort of a patient that we will not do to that kind of patient now. But that is the kind of patient that I start first. And that's why I think at that time, Dr. Vivian, is Vivian coming? Jason? Yeah. So there's a sharing notes things about me and actually Dr. Vivian actually looking at how do you approach this and everything. So from there on, then we get wiser and wiser and knowing the total indication. But the practice-wise, either in private or in the public sector, we do have issue with reimbursement. We do have issue on how we done. And then in the first setting that we discussed a lot with some of the insurance company as well. And I hope we can share with you that on that experience, and you can actually tell us your experience as well. Because the coding is not part of what we have in the MMA scheduling. So from the very beginning then that. All right, you. So I have to be, okay. So Dr. Samsa already know? Okay. So basically that's how I was grouped into this because of that. And then after a few patients, we can see not totally the pressure becomes superbly well, but we can reduce the number of the medications. And what we were actually experiencing at that time was actually, again, the long-term follow-up. And then after that, we were bombarded with a lot of evidence base. And if you look at the mix, I think we get lost in terms of the evidence base. There is actually evidence that you compare the phaco and phaco with mix, and we have a few, long-term. One of them is actually available on the paper in front of us, the long-term 5-year study. There's another product, the same thing like iStent, which is looking at trabecular meshwork. We call it Hydrus. The Hydrus have Horizon paper, 5 years down the line, also actually saying that bypassing trabecular meshwork during the cataract surgery in the patient with a POAG actually retain the freedom of the medications longer. So all that information that we come in, for me, a non-glaucologist that trying to help a patient, and I thought that, okay, there might be actually a way that I can actually contribute something. Okay, so we are opening now.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and a very good afternoon to all of you. So I've been asked to share my experience of iStent implantation in UKM. And this is not a solo performance. At that time, I was operating with Dr. Tang Sangfai, right at the back. Okay, so this compilation of data is from both of us. It's not just from me alone. Next slide. There's a disclaimer that I have received grant for preparation of data in this talk. Next slide. So in UKM, because we understand that the ability of the iStent to reduce IOP is only so much because of the ceiling effect of this device, therefore our indication to implant IOP is number one. If the target IOP is not achieved, then the indication would be to achieve lower target IOP. on the same number of medications. So that's what we tell our patients. It's not to stop all medication, but to reduce, it's not to, so the patient will get the target IOP with the same number of medications. But in this case, the baseline IOP should not be too high, because then we will not achieve our target IOP. So I take about 25, 26 of baseline IOP pre-op, so that I know that if the IOP goes down to about 18 or 19 or 20, then if that is my target IOP for that particular patient based on the Humphrey visual field, then that's fine. Previous slide, please. The previous slide. And if the target IOP is already achieved, let's say the pressure is about 15 or 16 on 3 or 4 medication, then I tell the patient, here the indication is to reduce the number of medication, achieving the same IOP. So that's how we practice in UKM. Next slide. So the iStent is either put in stent alone, in which the eye has got a clear lens or a pseudophakic eye, or combined with cataract surgery. In this case, the iStent is put after putting vision blue, staining the anterior capsule, followed by viscoelastic in the AC, and then the iStent put in. Next. And post-operatively, the normal ones, topical antibiotics. The topical steroid, I try to be as brief as possible. So a maximum of 2 weeks if it's a standalone procedure, no more than that. And a maximum of 4 weeks topical steroids on combined procedures. And this is to reduce the risk of steroid response in our patients. Next. So now I'm going to share our outcome from what we started off in December 2019 till the last iStent that we could collect, which was in March 2022. And we reviewed the medical records, all of the patients. Next. So we then define our successes based on the guidelines on reported surgical outcome based on the WGA recommendation, which is complete success if the pressure is more than 20% reduction without medication, and qualified success if the pressure achieved more than 20% with medication. And we also assess our safety profile. Next. So we had 53 eyes from 40 open-angle glaucoma patients. 44 of them were primary open-angle glaucomas, and the rest were secondary open-angle glaucomas. 24 eyes were standalone, 29 eyes were combined with phacoemulsification. 13 eyes received G1, because that was what we started off with, and it's cheaper. But when G1 was phased out, then we just put G2 or GW in all our eyes. So that's 40 eyes. Next. So about 2/3 of them were mild to moderate glaucoma, and we do put some in severe glaucoma or advanced glaucoma, because the understanding is that if we could achieve the targeted IOP with the iStent, then we went ahead and put the iStent there. So it's not entirely based on what the FDA approved for the iStent. Next. And these are the profiles of our patient. About 2/3 of them are primary open angles. We do put on normal tension glaucomas, steroid-induced glaucomas, juvenile open-angle glaucoma. So this was one patient on 2 eyes. So that's number of eyes. Pseudo-X glaucoma in 1, Bosner-Schlossman in 1, and angle recession and Gossack glaucoma both 1 eye. Next. So across the board, we do see reduction of IOP. And the maximum reduction seen was at 6 months, and this plateaued up till a year of follow-up. But you can see pressure starts to reduce almost immediately. So because of that, I don't stop the anti-glaucoma immediately. I still keep the patients on whatever they are on and slowly taper their medications depending on how their IOP behaves like within the first few months. Next. And we do see reduction in number of medications, although all of you can see that at 1 year, the patients most of them are still on some kind of anti-glaucoma. Next. So when we observed between the combined and the standalone procedures, we found that those who had a combined procedure had lower IOP over the course of 1 year compared to those who had iStent alone. So in other words, there is a contribution of IOP lowering by the phacoemulsification. Next. And also you see the number of glaucoma medications were less in the combined procedures compared to the standalone ones. And this is seen also across 1 year. Next. So you get about 2.6 millimeter mercury reduction from baseline after a year in both groups, although the standalone ones had higher IOP at baseline compared to the combined one. And both groups of patients or groups of eyes had about the same reduction of medication, although the standalone one had more reduction in number of medication compared to the combined group. Next. So looking at overall surgical success, that's about 44.4% after a year. But because our understanding of indication for iStent in this group of eyes is almost entirely impossible to get eyes without medication, and therefore our complete success is only actually 1 eye in the combined procedure, which is 5.3%, and no eyes achieve complete success in the standalone procedure. But if you look at those on medication and achieve 20% reduction in IOP, then you do see about 60% of success rate in the combined group versus a lower percentage, which is about 26% in the standalone group. Next. And these are the adverse events that we see. Most of them have very transient, mild hyperemia, which doesn't need any intervention at all. Some eyes, sometimes we overlook the topical steroids given, so they do develop high pressures, especially after 2 weeks or a month, depending on, some of them are younger and therefore they steroid respond faster. So 4 eyes develop high pressure from steroids, but all pressures came down after we stopped the steroids. A few eyes developed synechiae. That 2 eyes who developed synechiae is from the same patient, and 1 eye had occluded stent after a year. So that brings about to next slide, please. 1 eye receiving agar laser iridoplasty for the occluded stent that we attempted, but that eye eventually needed trabeculectomy alongside 3 other eyes which required trabeculectomy to control the pressure within a year. I think that's it. Yeah, next. So that's our experience. I'd like to thank my student, Dr. Koo, for collecting the data, as well as Dr. Tang, who contributes part of the case series here. Thank you. I think that's all. Thanks.
I think I just yelled.
Okay.
Everybody can hear me, yeah? Thank you, Prof. I think because we have a Q&A later on,
Sure.
I hope you stay on with us.
Yep.
Right, okay, so that's very interesting. I think very moving to know the result that you share with us. Thank you for that, and you did a good job on analyzing it as well. I think we're going to proceed now. We're going to proceed now to Dr. Leonard Lee. Am I correct? Is the presentation ready? Dr. Leonard, thank you with us. Thank you.
Yes, I'm more than happy to stay until the Q&A. Yes. Yes, thank you for the kind introduction. Yes, I can. Very well, thank you.
I will not on it. It's just a matter of like, for the photos. No, I'm just joking. Okay, so I think we have your presentations over here, and we do have a lot of questions that we want to ask you as well, Dr. Leonard, if you stay with us. We appreciate your time. I think that I'll let the technician to actually play your presentation. Thank you again for being with us, Dr. Leonard.
Thank you for the invitation to join you.
Good afternoon, everybody, and thank you to the Malaysian Medical Association for the invitation to speak at the iStent 4th user meeting. My title today is iStent 5-Year Experience in Singapore. And these are my disclosures. It has been almost 3 years since we last shared our surgical experiences. Today, I would like to sum up the last 5 years of using the iStent. We have all gone from little or no experience in angle surgery to where we are now, appreciating what it takes to make angle surgery work for our patients. I hope to show you through videos my personal learning journey, but I'm sure it will resonate with your own learning journey. Simply, I will cover the view from the gonio prism, the procedure itself, and postoperative care. First, let me illustrate with this video what we have learned about the importance of a good intraoperative view of the angle. The goal is to find the right combination of head and microscope adjustments to optimize direct viewing of the angle parallel to the iris plane and facilitate proper entry of instruments for surgical manipulation. This is the now familiar surgical gonioscopic view of the angle. The video shows progressive increase in microscope tilt toward the surgeon and the effect on good visualization of the angle structures. How nothing distinct of the angle seen initially becomes conditions suitable for implantation. Many of us started surgery using the Swan-Jacob or Hale lens and then moved on to the disposable iPrism S. We are fortunate that over these last 5 years, surgical gonio lenses have continued to be developed and released commercially. Personally, I still continue to use the iPrism S. Let's move on to the implantation procedure now. As you know, iStent implantation can be performed as a standalone or combined procedure, and even toric intraocular lens implantations are not impacted by the procedure. Here's an early video I made in 2017 of standalone implantation using the original iStent Inject. In contrast with the next video I will show you from 2022, you'll see a different generation of surgical gonio prisms, injectors, and also surgical technique. In this 2022 case, the Schlemm's canal is easily visible from the blood blush. To get good separation between the iStent Inject W stents, it is common now to shift the microscope and seating to facilitate wider spacing between the implants. I will further cover how the injectors have changed, what use cases we now have for iStent Inject, how we handle issues like overimplantation and underimplantation, and how we try to improve implantation and confirm good implantation. In these last 5 years, we've seen 3 versions of the iStent injector. Pictured here is the CE mark injector on the left and the latest W injector on the right. The most obvious external change is that the microinjector sleeve in the W injector is now blunter. Pictured here is the injector casing of the original iStent Inject, which I pried open in 2017. The most important change I feel is in the spring mechanism, which is now more consistent in strength between shot 1 and shot 2. Next, how have our use cases in glaucoma patients evolved? Obviously, we all started with on-label use in primary open-angle glaucoma. But as the experience and confidence grew, we started using it in normal tension glaucoma cases to reduce the medication burden in those patients. More controversially, we also use it off-label for primary angle closure glaucoma cases in combination with cataract surgery. In the interest of time, may I refer you to our publications on outcomes in primary open-angle glaucoma. And likewise, for our experience in using it in normal tension glaucoma cases. This is our just recently published prospective 1-year study of using combined phaco iStent in normal tension glaucoma. This next video compilation shows 2 cases of surgery in angle closure eyes. The first case has significant peripheral anterior synechiae present. This requires initial goniosynostolysis with a cyclodialysis spatula before implantation. Nowadays, the injector sleeve of the iStent Inject W injector with sleeve down may be gently used instead of a cyclodialysis spatula. The second case begins after cataract surgery has been completed, and how removing the lens and judicious viscoelastic has opened up the angle nicely for implantation to proceed. Let's move on to talking about overimplantation. We have all heard the reason overimplantation is to be avoided. This shows an iStent Inject implanted in a human anterior segment culture. The intent is for the head to end up within Schlemm's canal, and this occurs when the flange region is compressed against the trabecular meshwork region. Overimplantation, however, may position the head beyond Schlemm's canal. Fortunately, the likelihood of overimplantation has been reduced with the introduction of the iStent Inject W with a wider flange. Before the W and before the spring improvements, there was more variability in the procedure. In this video, I have unfortunately overimplanted both my iStent Injects. This is the second time I was using the iStent Inject W, and I guess learning the limits of its tolerance. But as you can see here, the iStent Inject W can still be overimplanted. This was a technique to do with overimplantation presented at the World Glaucoma Congress Video Festival. It had 5 main steps. Circle around the circumference of the iStent. Pull the trabecular meshwork tissue away. Tumble out the iStent. Reload and reimplant. This is an alternate technique to deal with overimplantation. Micrograspers from an MST set are used to retrieve the iStent. The iStent is then externally reloaded. The iStent is then reimplanted. Now let's move on to underimplantation. Underimplantation is less of a problem than overimplantation. This is an older video showing underimplantation with a CE injector. The implant was pulled out partially during withdrawal of the trocar. The then sharp injector sleeve tip is used to push in the implant. This is an alternate technique to deal with underimplantation that I used previously for the older FDA-approved injectors. With the older stents and injector springs, it was better to err on the side of underimplantation than overimplantation. The side of the micro insertion tube is used to nudge the iStent inject against the trabecular meshwork. There is, however, risk of the trocar causing injury during the nudge. This video shows the current iStent Inject W. With the wider flange of the iStent Inject, it has now become easier to do the underimplantation nudge with the blunter injector sleeve tip. This is again an iStent Inject W. An alternate technique is to use the phaco IA tip with the infusion off to nudge the iStent in. Here is a series of 4 photos. The first photo from the left shows a frame from my surgical video with an iStent Inject W with flange snug against the trabecular meshwork. The second photo from the left shows an anterior segment OCT taken the next day with Schlemm's canal adjacent to the iStent arrowed in red. The third and fourth photos show cuts through the iStent with the iStent head in Schlemm's canal. The proper placement is the aim of our surgery. Another concept that we have learned over our 5-year journey is that of targeted placement. It is the concept that iStent injects should be implanted as close to collector channels as possible to optimize aqueous outflow. As illustrated by this paper, collector channels are most numerous infero-nasally and found close to areas of increased trabecular meshwork pigmentation and areas of good blood reflux in Schlemm's canal. The next video gives a demonstration of targeted placement using trabecular meshwork pigmentation as a guide. In this case, there is no blood in Schlemm's canal to guide implantation. The area of trabecular meshwork between the blue arrows lacks pigmentation and are poor implantation sites. The area shown by the left and right red arrows looks more promising. Take note of the area marked by the down red arrow, which we will see later. It was to the right of center of the view. The first iStent is placed in the pigmented area. Thereafter, the microscope is shifted to reach the pigmented area that was almost out of view to the right earlier. The down red arrow, which we saw earlier, is now to the far left of the view after shifting the microscope. We are rewarded with good blood reflux during the subsequent IA. Early in our surgical experience, we wanted to prove to ourselves that we had established an anastomosis between the anterior chamber and the episcleral venous plexus. This video shows those early attempts. Shown is the internal position of the iStents in relation to the surface blue dots. Now pay attention to the area highlighted by the blue arrows. The external episcleral venous flow is seen to blanch from the effect of intracameral flushing with balanced salt solution. The same effect is seen at another region highlighted by the next blue arrow. Next, we discuss post-operative iStent care. This is generally simple. We now know that steroids can cause an intraocular pressure spike and that judicious scaling of post-operative steroid eye drops can prevent these. We also know that post-operative hyphema, if encountered, is usually self-limited and only rarely needs a washout. The prevention of severe hyphema is best avoided by careful case screening for patients on oral anticoagulants, novel oral anticoagulants, and on renal dialysis. Finally, iStent obstruction by iris may occur in up to 10% of cases, but fortunately can be dealt with by laser iridoplasty. This was my first laser iridoplasty in 2017. The lower iStent central inlet is completely obstructed by iris. A Pascal laser is used to do a small spot size iridoplasty to clear the obstruction and prevent a recurrence of obstruction. Thankfully, this is passé now, but back then there were no YouTube videos to learn from. Let me end my talk with this last video, which shows proof that the iStent inject is working in this eye. This is from the first post-operative day. At the nasal limbus, increased episcleral venous flow can be seen across a wide region, but is most obvious in the region of the blue arrow. So let me summarize our 5-year experience by saying that we've come a long way in angle mix. The surgical experience has been made better due to periodic equipment upgrades, and over time, we've learned how to do the procedure better and safer. Thank you for listening.
Thank you so much.
I'd
Dr.
just like to acknowledge the great glaucoma at Tan Tock Seng Hospital, Singapore.
Have acknowledgement. Sorry. Dr. Yip, Leonard Yip, you still with us?
Yes.
Okay,
Yeah,
if you
yes, I
can
am.
stay with us, thank you so much. Your videos is always amazing. You know, it's always like enjoy to watch the skill that you have and the learning journey that you have. So we appreciate that. So if you just wait for another 20 minutes for us to have a Q&A session, appreciate that. We do have another speaker, Dr. Colin Clement. Dr. Clement is actually from Sydney Eye Hospital. Is Dr. Clement with us? Hi, Dr. Clement.
Yes, hello.
Yeah, appreciate that you'll be with us. A bit delayed. I know it's 7 o'clock in the evening over there in Sydney. It's a vibrant city. Saturday, you're spending with us. There's a lot of sacrifice there. We appreciate that.
My pleasure.
Okay, thank you. So I think, after listening to the previous two speakers, we're looking forward to your experience as well in this. And we hope that, you'll be able to highlight to us again your journey in using the iStent in your practice. So if you're ready, sir, the floor is yours.
Okay, thank you. So I'm going to share my screen now. I'm not able to share the screen. The host needs to enable that for me, please. I can't share my screen at the moment.
Okay, so just hang on there. We just actually
Okay.
change the setting over here. Just let us know if, let's say, you're unable to hang on. Just hang on a sec. No, don't do that. It's just actually, yeah. You okay? Okay, can you actually...
Okay, good.
Okay, cool.
Yep.
Thank you.
Uh, Okay, well, thank you very much, Glaucos, for the invitation to speak at your meeting. It's indeed a pleasure to be with you. I'm sorry I can't be with you in person, but this is the next best thing. I'll apologise at the outset. I do have an upper respiratory tract infection like most people in Australia at the moment. So if I cough, I do apologise, but that's the reason why. So I've been asked to speak to you about iStent Inject W in glaucoma, cataract and treatment algorithm. These are my disclosures. All right, so iStent Inject W. We heard Dr. Yip give a nice overview of what the iStent Inject W is and how it differs from the original stent, and I've repeating that slide here. The main difference is that the flange is wider. It's now 360 microns as compared to 230 microns for the original iStent Inject. And the reason for this design change is to stop over-implantation of the stent, and it's had a positive impact. We rarely see over-implantation now as a result of this design change. Here is the stent and the injector. The stent comes preloaded with two devices. It's used like a pen with a trigger on the top, which is deployed, and it fires the stent into the trabecular meshwork. All right, so when we're talking about the glaucoma and cataract treatment algorithm with respect to iStent Inject, one of the important things to bear in mind is what is our overall goal of glaucoma treatment. Now, when you ask this question, the common answer you might get back is it's to lower intraocular pressure, or it's to preserve glaucoma, to prevent glaucoma-related visual field loss. But actually, the primary goal of any glaucoma treatment is to maximise quality of life. And we do this by preserving vision, which in turn we achieve by lowering intraocular pressure. So although a lot of our treatments are primarily targeted at lowering intraocular pressure, it's two steps removed from our ultimate goal, which is to maximise quality of life. The problem is that when you start glaucoma patients on treatment, there is a fine balance, because some of our treatments have an adverse effect on quality of life, which is contrary to what we're trying to achieve. Now, in the case of medications, this could be side effects from them, the inconvenience of using them and the costs. There can be adverse events from surgical interventions. And then, of course, there's the costs, both in terms of time and money for the treatments, attendance at appointments, etc. Now, if you look at quality of life overall as a function of disease severity, it's only mildly affected in pre-parametric and mild glaucoma, and as the disease becomes more advanced, quality of life declines. Now, that is likely largely to do with the effect of the glaucoma on the patient overall in terms of their quality of vision. But there's also a component to that which comes from the treatment, because as glaucoma becomes more severe, treatment is escalated and they have more and more side effects and they're exposed to greater risks. So in eyes that are pre-parametric and mild, you can see that where the quality of life scores are high, they're very sensitive to the effects of anything that's going to diminish that. And when we're looking at quality of life, these are the types of things from our medical treatment that can have the opposite effect to what we're trying to achieve. So there's the ocular surface problems. So the patient on the upper left has signs of prostaglandin-associated periorbitopathy in the right eye. They've had a trabeculectomy in the left eye. There's the patient in the middle has a alpha-GAN hyperemic conjunctivitis. And then the image on the right shows severe ocular surface disease, which is common with anyone taking topical glaucoma treatment, and the incidence increases when they're taking more than one treatment. And apart from the ocular side effects, there's also systemic side effects. So, beta blockers are well known to cause bradycardia. There can be neurological side effects from the treatment, and even beta blockers affects pulmonary function. So all of these things will reduce the patient's quality of life. So that's one important thing to take into account when you making a decision about in whom you're going to offer these treatment. The other thing is that you will have local regulations in place which determine funding and who can get access to the stent and who cannot. In Australia, we have a couple of item codes for reimbursement. We have one for combined surgery with cataract. And that defines someone that is suitable if they've been diagnosed with open-angle glaucoma and they're not adequately responsive to topical anti-glaucoma medications, or they're intolerant to anti-glaucoma medications. Now, that's open to interpretation. Excuse me. The other code is for standalone, and that's for a micro bypass stent through the trabecular meshwork if conservative therapies have failed or they're likely to fail. And the second point here is that the service has to be provided by a specialist who's had recognised training in the use of ab interno trabecular bypass stents. So that code is a lot more restrictive. And then the other thing you need to take into consideration when deciding in whom you're offering this surgery is why are you actually doing it? And it may be because you're trying to reduce the patient's IOP. It may be that you're trying to reduce their medication, or actually you're trying to achieve both. Now, I'm going to present you some data a little bit later in the presentation, but I'll give you a sneak peek now. This is from the Fight Glaucoma Blindness Registry, which is an Australia-wide registry point of care, where we've recently had a look at all the iStent data, and this is in press as we speak. And we have 970 eyes with 12 months of follow-up. And what we've found from that is that 75% of eyes achieved IOP reduction, 51% of eyes achieved medication reduction, and 46% of eyes achieved both. And I'll go into a bit more detail about those definitions later on. Okay, so here we go. This is the algorithm. This is what goes on in my head, and I've put it down onto a slide here for you. I've categorised it into two groups. First is opportunistic iStent inject W. So this is for patients who have visually significant cataract, and there's an opportunity there to add iStent inject W because of the potential benefit to the patient. So the first question I ask, we know that they have a visually significant cataract and they need the cataract taken out. So the first question I ask is, will the angle open at the time of the surgery? Because if the answer is no, then they shouldn't receive an iStent, in my view. If the answer is yes, I then ask myself, are they on ocular antihypertensive medications? And if the answer is no, well, first of all, we'll say if the answer is yes, well then, for me, I will always offer them an iStent inject W combined with cataract surgery, because there's an opportunity to reduce their medication burden. And even if their intraocular pressure control is very good, the overall impact on their quality of life is going to be positive. Okay? If the answer is no, then I ask myself, does the pressure require lowering? If the answer is no, well, then they don't need an iStent inject W, and I won't offer it to them. If the answer is yes, then I will offer them iStent inject W in combination with the cataract surgery. The second group is targeted iStent inject W, and this is for patients who do not have visually significant cataract. So the first question I would ask in these patients is, are they on maximum tolerated medical therapy? So if the answer is no, then there's an opportunity to better control their glaucoma with medications. So at that stage, I probably would not offer iStent inject. If the answer is yes, well, then we go to the angle question. Is the open angle? Is the angle open, sorry? Or is it likely to open at the time of surgery? If the answer is no, then they don't get an iStent. If the answer is yes, you've then got to look at conventional surgery risk versus reward. Now, that's very subjective, but it's important, and it's something that's considered both by the surgeon and the patient. So if you feel that the risk associated with conventional surgery versus the reward is favourable, so i.e. They need a low intraocular pressure to achieve stable advanced glaucoma, and without that the risk of progressing is high, then in that case you would progress to trabeculectomy. However, if the risk is bad, then I would consider doing iStent Inject W first before progressing to more risky surgery. And sometimes your patients will come to you and say, we've had a chat about trabeculectomy, for example. I've gone and done some reading. I've looked at the information, and I'm really not comfortable with the associated complications and the length of recovery. I'd like to try something else, please. And that actually happened to me last week. So in those cases, I would consider the iStent Inject W as a standalone. And then you know, if the patient's pseudophakic, you don't need to worry about anything else. But if they're phakic, then it's worthwhile asking, even though they're phakic, is there any potential benefit to the patient in combining this with a phaco? And one scenario that I've come across where that was the case is, you know, very high myope who's contact lens dependent, and they're on 4 agents, and the medications are interacting with their lenses. They're getting ocular surface disease. They don't have any cataract, but taking out the clear lens and reducing their myopia reduces their contact lens dependence. So it makes their vision better overall. And it also prevents the medication from interacting with the contact lens on the surface of the eye. So they're my algorithms. So now I'm going to move on to, I've got a couple of videos here. I just, it's all good and well to think about patient selection, but at the end of the day, you need to put the stents in correctly. And if you don't do that, they're not going to work. Now, one point I want to make here is that it's important to inflate the eye firmly. And what you can note here is that the view of this angle is very, very stable. We're not getting any folds in the cornea, which will obscure the view. Okay? Now, that's an under-implanted stent, and like Dr. Yip demonstrated, the tip of the injector is being used to tap it into place. So it's being tapped into place. The other thing you'll note is that there's no blood reflux at the time of injection, and that's another benefit of inflating the eye to a firm pressure. I actually think it's a disadvantage having hemorrhage reflux at the time of implanting the stent because it obscures the view. It can, in some cases, prevent you from seeing whether the stent is under or over implanted, and sometimes the blood can wash into the field where you're trying to implant the second stent, which makes life difficult. So my very strong recommendation to you is to inflate the eye firmly with a cohesive viscoelastic to ensure a very clear view and to prevent blood reflux. There's a little bit of blood coming back there. Now, what I do at this point is I do an irrigation aspiration under a gonioscopic view to check flow. And there we go. So that's confirmation that our stents are in the right location. Okay. Now, I've got another slide here for you. Now, hot off the press, we're currently enrolling for a study looking at the benefit of injecting 3 stents. So in order to do that, you've got to modify your techniques slightly. We're still aiming to get the stents 2 clock hours apart, which is difficult to do through a single position. So what I do with the 3 stent technique is to place one stent directly in front as so. And then rotate and try and position the second stent 2 clock hours away in that direction. All right. And then we'll fast forward. Sorry, fast forward. All right, and now we've got our third stent here being injected 2 clock hours away in the other direction. That one's a little under-implanted, so just give it a little nudge. All right, and like with the other case, once they're in place, we get the irrigation aspiration under IA, under gonioscopic view, sorry, and remove the cohesive viscoelastic. Just fast forward there. Sorry, the end of the video is truncated, but what we see when we get to the end is that there's blood flowing from the 3 stents. And then finally, I just wanted to show you this one. This is a standalone case. So the difference between this and the other cases is that for standalone, I myose the pupil prior to surgery. And this is particularly important for phakic eyes because it minimises the chance that you're going to inadvertently touch the lens capsule and induce cataract. So you can see in this case that the pupil's myosed, but for combined cases, it's not necessary to myose the pupil. And again, this patient's receiving 3 stents, so the technique is the same. One in the middle, and then 2 clock hours to one side, and the other 2 clock hours to the other side. Okay. I'll just fast forward, and we'll see the. Yeah. Okay, so we'll move on. All right, so the last part of the talk is just to go through a little bit of data. So I've got 2 studies to present to you here. Both of them are in press at the moment. So this is our Australian cohort study, which is data from 6 practices across 3 states, which we've been following over, we've got 36-month data now. And this is for 273 eyes. So with a baseline pressure of 16.4, by 3 months come down to 12.9, and then out to 3 years the pressure reduction is 13.9. So it's 15.5% reduction overall. This is the number of eyes achieving a IOP less than 15, comparing baseline and 3-year follow-up. So it's at 3 years it was 70.3% versus 49% prior to surgery. And then those achieving less than 18, it's 92.7% at 3 years versus versus 75.8% pre-op. This is the mean number of medications. So pre-op was 1.51 medications. By 3 months, this had reduced to 0.49, and this is maintained out to 3 years at 0.48. So that represents a 68.5% reduction in medications. And this is just a breakdown in results for glaucoma subtypes. So that one of the interesting things about this cohort study is that there's a mixture of glaucoma types. We've got null tension glaucoma, primary open-angle glaucoma, primary angle closure, and ocular hypertension and glaucoma suspects. And in all subgroups, there was improvement in intraocular pressure ranging from 12.5% through to 22% reduction at 3 years. All right, so that's the cohort study. This one I'm very excited about. It's the Fight Glaucoma Blindness Registry study, which I briefly mentioned at the beginning. And this is from a point-of-care registry that's used in Australia, where we collect data through clinical practices, and it's all anonymised and help maintain through the University of Sydney. Now, we've been through the registry and extracted all the iStent data. we already have one publication from that now. That's the study looking at hydrus versus iStent combined with cataract surgery. And this is the second study which is currently in press. So this is outcomes for iStent Inject and iStent Inject W in combination with cataract surgery with follow-up up to 36 months. So you can see at all time points, 6 months, 12 months, 24 months and 36 months, there's a reduction in intraocular pressure from baseline, and that pressure is maintained around 14 millimetres of mercury. Similarly, the medications is reduced, so it starts at around 1.6 prior to surgery and is reduced to 0.6 at 36 months follow-up. The histograms on the right for 6, 12, 24 and 36 month outcomes of IOP versus pre-op IOP for each individual eye entered into the registry. So any data point that lies to the right of the dotted line is improvement in pressure, and any data point that lies to the right of the solid line is improvement in pressure of greater than 20%. This is the Kaplan-Meier survival results, which I mentioned to you earlier on in the talk, showing that any IOP reductions achieved in 75% of eyes, any medication reductions achieved in 48% or 49%, and both in about 45%. Now, I'm of the view, and my co-authors are of the view, that applying standard glaucoma surgery outcome parameters to this intervention is not appropriate, because it's okay to do it, but you shouldn't do it in isolation, I don't think, because those parameters were devised for surgeries that used for treating advanced disease, where large pressure reductions are required to achieve the desired outcome. So we're talking about trabeculectomy, tube surgery, transscleral cyclodiode treatment. When it comes to iStent Inject W combined with cataract, as I've already alluded to earlier on, you don't necessarily need that size of a pressure reduction to achieve your treatment goal. In some cases, you don't need any pressure reduction at all. All you're trying to do is reduce the medication burden. So what with this definition, we're looking at any IOP reduction is any patients whose pressure is lower than their baseline on the same or fewer medications. And any medication is anyone who's at the same or lower IOP, and they've also achieved reduction in medication. So I think that information is useful, because when you're discussing this surgery with your patients, they often ask you, what is the chance that you'll achieve my pressure going down, or what's the chance that my medication will go down? And now we have something of an answer to or results that we can discuss with them. We did some analysis looking at associations with achieving those outcomes, and we found that preoperative IOP had a hazard ratio of 1.14 for any IOP reduction, 1.08 for any medication reduction, and 1.1 for medication or IOP reduction, and that was all significant. So the higher your IOP, the more chance you have of achieving those outcomes. Preoperative medications, you had a higher chance of achieving any medication reduction, or both IOP and medication reduction, if you were on more medications. And the age of the patient and the gender of the patient did not influence any of those outcomes. Okay. Right, so in conclusion, I'd say that the quality of life is a very important endpoint to consider in your glaucoma management algorithm. iStent Inject W may help you achieve your quality of life goals. It is able to provide improved intraocular pressure control and reduced medication dependence, or both. And this occurs across a spectrum of glaucoma types and severities. And this data the data supporting its use is very robust with cataract surgery, and we're learning more and more about its benefit as a standalone treatment. And before I say thank you, I just want to remind you that the Asia Pacific Glaucoma Congress is in your hometown next week. And if you haven't registered to attend, I would certainly encourage you to do so. It promises to be a great meeting. And with that, I'll say thank you.
Thank you. Thank you so much, Colin. I know that you're struggling during the presentation with the cough and the flu that you have. We appreciate that you're taking the time. Would you actually be able to join us for Q&A? Because we don't want to hold you, knowing that you're not feeling that well. Are you okay to join us with Q&A, or we can just shoot the question to you now? Which one do you prefer, Colin? Can you hear me, Colin? It doesn't seem that actually Dr. Clement can hear. While Dr. Zul is actually preparing for the presentation, I think...
We've finished the presentation now.
Oh, after finish the present, yeah. So, would you like to have the Q&A?
Hello, we're finished.
I'm not sure whether Dr. Colin actually, there's a delay. Yeah. Can. Okay. Colin, are you with us? Okay. So I think we'll actually, Jason is actually WhatsApping with Colin. Okay, so he will be with us in Q&A. Okay, that's fine then. Then I think while Dr. Zul is actually setting up for the presentation, time and time again, I think this is convincing in terms of the patient choice from Prof. Samsia presentation, Dr. Yip presentation, as well as Dr. Clement presentation. Anything? Okay, yeah, okay. So I think if you look at the FGB data just now, they start off with 1 or 2 drops, at least 2 drops, and then they start giving the injecting the W. When I started, that is actually patient with 4 drops, which is just totally not indicated for that. And then we try to replace the iStent from trabeculectomy. And this is talking about when I started in 2016. So what happened is actually now we go to the up and coming young surgeon, Dr. Zul, basically sharing his early experience, and he's actually currently attached in UM for his glaucoma fellowship training. But what I think the thing even Prof. Samsia actually shared with us just now is actually that indication is very important. The FGV data actually shows that, Dr. Yip. And the other thing that's important is actually when I look at the FGV data, it's actually 6 months, 24 months, and 36 months. There's consistency on. Whenever that actually the patient asks me how long can this injection last, I usually quote. You can't do that? Okay. Can Dr. Zul present with the other computer? You trying? Okay. You can't read it. Okay, no problem. Okay, while we're waiting for that, we can have a Q&A session first. Anybody have any questions to the speakers? One of the things I want to ask Prof. Samsia is this, that you actually choose to do it before the surgery. No, it's just like when you do it standalone procedure. But in this, and your idea of doing that because you said the eye is a bit turgid and it's easy for you. Is that correct? Is there a microphone for Prof. Samsia? Oh, you can have mine. I speak loud. No, that's, yeah. Might as well use it since you pay for it. Okay. Okay. Right. So, anybody else here do it before the surgery? Can I have a show of hand? All right. Okay. Yeah. That's bias of the group. No, I'm just joking. Okay, but I do it after because less stress in my point of view. Less stress in my point of view. You know, after all that, and then patient get tired, beaten after the surgery, then it's less stress. So yeah, yeah. Can you comment on that?
Yeah, we prefer to put it before. Number one, of course, like you say, it's nice and firm, but also you get less bleeding, which is in a way good because if you get immediate bleeding, then your view is all distorted and you really can't see your stent and all that. But also, you know, sometimes when you put it after phaco, you have to overinflate the eye with viscoelastic, and that in a way, of course, you waste all your viscoelastic. Number one. Number two, it's a lot difficult to overinflate until the eye is nice and firm, as opposed to if you do it before phacoemulsification. Yeah, so I would prefer to do it before.
Okay. Anybody, the expert, have any comment on that? Dr. Vivian, you want to have a comment on that? Yeah. Oh, the question is standalone. Yeah.
For example, that patient doesn't want to put the drops. For example, 2 drops for a DPOAG, but phakic eye. Will you put the...
Yeah, we've put a few eye stents in phakic eyes, in which the lens is still clear, the vision is still 6/6, and so what we did was put myostat in, constrict the pupil nicely to protect the lens, and then do iStent as the usual manner. Not much difference. It's just that, you know, when you remove the viscoelastic, be extra careful not to touch the lens.
I prefer before.
Meaning that before you start phaco. Yeah.
Because clarity is very important. A lot of my patients, they have very bad ocular surface disease. And so by the time you finish phaco, the cornea will be a lot more hazier. You got lots of stuff in the AC. So if you have like, you know, small eye, you know, you're going to be struggling with it. So I prefer a nice, pristine to that. The only problem is if you're going to do it before your phaco, you can't touch the capsule. So that's but before, as what Samsia does, mine is because of clarity.
Yeah, I agree with that. I totally agree with the logic on that. You know, it's actually correct. I mean, you have a nice eye, pristine eye, good vision. Patient still with you at the starting point of it. You know, I found out when you do stand alone, technically it's easier compared to combine. After we do it after, so. I totally agree with that. The only thing that why I do it after, first, I don't want to tap the capsule. You know the technique, we see it nice, but the learning technique that I have is actually holding it and putting it in when it's not in the view, when you have to put the lens. That is when started, I'm worried about that because I don't know whether I'm going to touch the decimate or going down, you know, when you go in. It's just me. But yeah, that's point taken. I think, Dr. Yip, you still with us?
Yes, I am, yes.
Yeah, I think as we get experience with the procedure, we start to try the off-label use of the device. I think it's just a natural progressions of, you know, egocentric surgeon like all of us. One of the things that you showed is actually the PACG, and this is important because I think we know that from our own experience and then from the publication that when we do cataract in PACG, the angle is a bit open. I don't do a lot on this, but I found that if, let's say, just what you did, when you actually put a trocar in and then you actually just, you know, just sieve through the trabecular mesh, or not the trabecular mesh, the iris or whatever that's attached to that, you can have a clear view on that. But I saw you doing as well. So do you have any tips and tricks? I think it's still off-label. I don't think we actually should promote this, but I just actually taken by your technique just now. Do you have any tips to actually share with us?
Well, I think careful preoperative assessment is important. So I think if the initial preoperative gonioscopy shows that there is significant synechiae and it's hard to indent open, then this patient may not be a candidate for angle mix, because in those situations where I have opened up the angle by either using a cyclodialysis spatula or using a viscogonoplasty, I find that the angle landmarks are very difficult to read, because after synechiae, very often that whole area is just plastered pigment, and it can be very difficult to figure out where to put in the iStent, and it may not work if you don't put it in the right position. As opposed to an angle which is narrow but still open, and with indentation you can see that the landmarks look reasonable, then I think those are still very good cases to do after cataract extraction. So I think we're talking about whether to do the iStent before or after cataract surgery. For angle closure eyes, I would definitely do it after cataract extraction for those reasons. So preoperative gonioscopy is probably the most important thing for your decision making. We're doing a randomized control study now to try and decide whether phaco or phaco iStent is better, but we haven't got to its endpoint yet.
Okay, thank you, Dr. Yip. Thank you, Leonard, for that. Are we okay with the addition? Can we share with the Zoe presentation? Okay. Okay. Let's get that actually on the screen first, and I just ask us questions again to all the experts over here. And this is where I get confused sometimes. Dr. Zul, just one question before I go. We know that from the study, and this is actually established, that the collecting dark that actually working is infranasal. When I first started that, I thought that if I have to put 2, then I would actually go to the infranasal. Technically, it's challenging. In fact, technically, is you just put whenever that you can put, depending on the patient. Because your hand is, I mean, this is my hand. Your hand might be stable. Your head is jittery. The patient might be moving. But after a while, when you get used to it, you want to place it right. This is actually both speakers or all speakers is talking about that. Now, if I think logically, then I would actually try to aim on the nasal side and the inferior side if I want to do it. But that's not easy technically, and that's why you can see that we do it, like. So I think, Colin, you did mention that you are doing the study now with the 3 incision of the W. Am I correct? Is Colin with us?
Correct. Yes, that's right.
So I mean, the theory of segmental outflow is there. Does it actually tally with the practice that you're going to suggest to us, or it's just like you just put it whatever you can put, like what you showed, that you go to like central first and then you just get almost 2 clock hour apart? Well, what's your comment on that, Colin?
So I think in wet lab scenarios, it's been shown that when the stent's correctly placed, you get about 1 clock hour of aqueous flow either side into the channel. So if you place them at least 2 clock hours apart, you can certainly do more than 2 clock hours, but that's technically difficult. But if you do it at least 2 clock hours apart, then you're maximising the amount of the Schlemm's canal that you're accessing, at least 4 clock hours. With regard to the 3 stent study, the reason we're doing that is it's primarily because Glaucos are looking at developing a device that comes preloaded with 3 stents, and we just want to compare the safety and efficacy compared to 2 stents, and then from there you can make a judgment on whether any gains that are achieved over two stents are worthwhile putting a 3rd one in. I don't have any data on that yet. We've only been enrolling for 6 months. Anecdotally, it looks good, but I couldn't tell you if it's better or worse than 2.
Okay, thanks, Colin, for that. I think we actually just, Dr. Zul, okay, can we actually have a look at the presentation? All right, you. Okay, so that's okay. So we invite Dr. Zulhelmi from IIM Kuantan. His initial experience using the iStent. Okay, Dr. Zul. That's UKM. You haven't changed university yet, right? Not that I know of. No, this is a problem when you send somebody to KL, and then they discover KL have more to offer compared to Kuantan. Next time I send you to Ipoh. Maybe Manwai I can actually convince something else. Okay, that's it. Okay.
Okay, Assalamualaikum and very good afternoon. So I'm Dr. Zul from Kuantan, but now I'm in KL, in PPUM. Basically, I was surprised to be, I was asked to stand over here. So I was surprised to be one of the speakers, but Jason keep asking me to share our experience in UIA. I think maybe he cannot find another one, so he just asked me to speak today as well. So basically we started using an iStent implant back in 2017. Perhaps at that time not many surgeons have implanted iStent, so they tried to introduce it in the Asian market before. At that time, if I'm not mistaken, I with a few other people, I think Dr. Suresh, was sent to Singapore to learn the proper technique from our great surgeon in Singapore. I think, if I'm not mistaken, Prof. Shelvin, Dr. Shamira, and we were sent there, I think twice. And after that, we started putting implants and iStent in Malaysia. So, of course, the thing is, the learning curve is quite challenging, I think. But the main reason is I think in Malaysia, because of the cost factor. So it's a bit difficult to get a patient to pay such a high price in Malaysia. But with time, I think we have more patients now in Kuantan, and surprisingly, I can say 60 to 70% of our patient is self-paying patient. They are willing to pay on themselves. So I think I just give a short presentation. My presentation is just simple, and I think you should just enjoy it. Okay, next. Okay, now it's start. So okay, I just display. I have no financial interest in the matter presented. Apart from they sponsor me the room in this hotel. So next. Okay, I started my presentation with a few case presentation. It's just a simple presentation. So this is the first case, Madam NBK, 70 years old Chinese lady with high myopia and hypertensive. Actually, patient was diagnosed with primary open angle glaucoma for 5 years and treated with 2 anti-glaucoma. Basically, she was treated at other centers, and somehow she ended up at our clinic, and she wanted to have the cataract done there. And when she first came to the clinic in 2019, the IOP was 19 and 24, even with that 2 anti-glaucoma medication. The AC is deep, angle is open, and the cup-disc ratio is around 0.6 and 0.7. So we proceed with phaco. Actually, we offer phaco, and at the same time, because patient is also glaucomatous, we did offer iStent at the same time, because I think in the beginning of our journey, we started all our iStent cases combined with phaco. We don't dare start iStent alone, because we think that to do it with phaco simultaneously is actually much more easier. Last time, I think my opinion is the same with Prof. Hairizan. We think that if we do the phaco first, we can open up the angle a little bit more, so we have more view. So because of that, we can have a better view, and we can implant the iStent better. But I think other surgeons, they have much more experience, perhaps the implanted iStent before surgery is better. But for us, I think after the putting the lens and then we put the iStent. So we put in the G2. The left eye was done on the 10th of October, and about 5 months after that, we do the right eye. Next. Okay. There you go. Can you play the video? So I think it's, yeah, the video is not playing. This is actually just want to show you the iStent. Actually, we finished the cataract first. We put the lens, and then after that, the thing is because I think for me, I'm more comfortable to do the surgery at the top first, and I'm doing the surgery by manual. So I already have the side port which is within the 15 degree, and it's quite big to put the iStent using the same wound. But the thing is, after I finish my cataract surgery, I need to move the table and to set the microscope after that. As compared to those who are doing the surgery right at the temporal in the beginning, they don't have to change position. But for me, I think both me and Prof. Harizan, we prefer to do the surgery at the top, and then after that we change the table. Okay, tapi it's okay. Next. Next slide. Yeah. So just want to show you what's the IOP pattern for this patient. So pre-operatively, patient was on 2 anti-glaucoma. The IOP was 19 and 24. And after we do the surgery, usually I stop all the anti-glaucoma medication because I want to see how's the IOP pattern. No, just yeah. So I stop all the anti-glaucoma, and then I'll see what is the pattern of the IOP, and we continue monitoring. So post-operatively, patient just apply the antibiotics eye drops and as well as the steroid eye drops, and we continue monitor the IOP up to day 30. The pressure is still maintained, and up to 2 years for this patient, the IOP is 13 and 16, maintained and without any anti-glaucoma medication. So this is the second patient, Mr. TMK, 72 years old, Chinese gentleman. History of POAG for 4 years, treated with 4 anti-glaucoma. Actually, he came to the clinic, also want to do the cataract there, and the IOP was not well controlled. It was high, 25 and 31. Actually, this patient was advised for Trebec, and we would like to refer the patient to the glaucoma surgeon, but unfortunately, patient not in for Trebec. He just want the cataract to be out. So because of that, we offer him iStent just to help in terms of reducing the IOP a little bit. Then it may help reduce the medication burden. So the okay, next slide. So we do the phaco iStent. The left eye on the 2nd of May, and 1 month after that we do the other eye. Next. I think this video also cannot play. It's okay. Actually, I just want to show you how we start the learning curve that we have. The problem with putting an iStent in the beginning is to get a proper view. Sometimes you don't put enough visco in the AC to maintain the AC volume. Sometimes when you there's a blood in the surface of the eye, for example, if you you make your wound too posterior, or sometimes you give a sublingual injection, the blood can mix with the visco and it also affect your view. And sometimes they also bubble in between the gonio and the cornea if your visco is not enough, or sometimes your positioning is off. So this is the patient, right eye 25, 21. Post-op day 1, both eye was, the pressure was around 12. So I stopped all the medication as well. I'm not afraid to start the medication later because we are still monitoring the patients. So continue. But noted that at 6 months post-operatively, the IOP start to goes up and is going to the borderline level. And after monitoring few times, then I start him with one more anti-glaucoma because the IOP is not really well controlled. And after that, I need to start 2 anti-glaucoma medication just to bring the IOP down. And now at 3 years, the IOP maintained at 15 and 13 around that level, low-tin, with 2 anti-glaucoma. And patients quite happy about it. This is the third patient, 72 years old male. History of open-angle glaucoma for 2 years. The right eye on 2 anti-glaucoma and left eye on 1 anti-glaucoma. First came to a clinic recently in February. IOP on the right eye is 18, left eye was 21. I see dips, open angle, and the cup disc ratio is about 0.8. Next. So I've just started doing the, I did the left eye cataract surgery in March this year because the patient complained because of the cataract. And at the same time, we offer the iStent and patient agreed and keen for the surgery as well. So this is the result. So at post-op day 1, I stopped all the anti-glaucoma, and post-op day 7, the IOP shot up to 26. But at that time, I just watched the IOP. I've not started any medication, and somehow the IOP goes back to 11 and 10 afterwards. And at the moment, the patient is without any medication for the left eye. So basically, this is just a small audit that we did from 2017 to 2020. We have more cases after 2020, but we're still collecting data and we can present it in later meetings. So from this duration, we have 15 patients. And this is the demographic data of the patient that we have. We have more female patients, Malay 12, Chinese 3, and most patient is open-angle glaucoma. So this is the mean IOP of each visit, comparing the pre-operative until up to 1 year post-operative. And you can see the numbers of IOP lowering agent also reduced from pre-op to post-operative at 1 year. I think that's all my presentations. Yeah, I think if you have any question, we can discuss later. Back to Professor.
Okay, thank you, Dr. Zul. We will actually continue with the Q&A, but I would like to invite Dr. Pushpa to actually have a video to share with us, to set it up and to show. While waiting for that, we're going to actually go for the Q&A again. I have a few questions. I think I managed post-operatively different from Dr. Zul. Dr. Zul actually off all medication. I would continue on with the medication and drop. So any expert actually have any comment on this? I think, yeah. Yes.
Hi, I'm Dr. Lu from Seremban. Okay, I have a slightly different approach to different types of patients. Okay, so far I have done 36 iStent. If the patients, whether or not I stop the glaucoma drops immediately depends on their pre-operative condition. If pre-operatively their IOP is I would say not, I mean, their glaucoma is not the very severe, uncontrollable ones, moderate type. If the IOP is around 20 plus minus with, let's say, 2 medications, then post-op, I will straight away take off all the medication, the glaucoma medications. However, if the patient is on 3 or maximum drops, then I will not take off all. My rule of thumb is always take off 2 and leave another 2 behind, or leave, whatever behind. And then number 2 is my guide is on the first post-operative day, the very next day. If the IOP is anything below 16, I will take everything off. And also from my experience, those patients where 1 day post-op, the IOP is in the low teens, they are the ones who will do very well over the long term. The moment that the post-op day 1 is above 16, then I will keep whatever eye drops they have, like just take off 2, and then we will monitor week by week. That's my way of, tailoring to an individual patient.
Thank you for sharing. If I call whether Leonard, Dr. Yip, or Colin, Dr. Clement, do you have any take on this?
Hi. I think I broadly agree with what the last speaker said earlier. I couldn't quite see her. Was it Dr. Lu? But anyway, I broadly agree with what she.
Dr. Lu here. Hi.
Yes, okay, it was Dr. Lu. Yeah, sorry, you're very small in my picture. So I broadly agree with what I think. If we look at the severity of the patient's glaucoma, so I think if it's a very severe glaucoma, very little field left, I'd be more hesitant to stop too many drops at one go. I think as a rule of thumb, I think I would agree with her, probably about 2 drops at any one time, and then. But in general, for those who are 1 droppers or 2 droppers, with not very high baseline intraocular pressures, I think it is quite safe to stop it preoperatively and then decide if you need to re-escalate again post-operatively if the pressures start to rise again. But I broadly agree with her. Thanks.
Colin?
My approach is also very similar. I tailor the post-operative drop use to the patient based on their disease severity and the initial IOP response. So if the patient has mild or moderate glaucoma, I'm much more likely to stop the drops straight away because they can tolerate slightly higher pressures in that post-operative phase whilst everything's settling down. Whereas if the glaucoma is quite advanced, I want the pressure as low as it can be, and I look at withdrawing medications later on once I know it's stable. Sometimes you can get high pressures the day after surgery because of high femur or retained viscoelastic, and you want to keep the medications going to get them through that phase.
Thank you. I think it's the same thing what Dr. Zul did, because it's a patient-to-patient basis. Because I've seen that the way he managed as well. I said there are patients that he actually maintain on the medication as well. So that's the take home that I think that we all agree that, when we actually decided whether to on and off, it is actually tailored to the conditions of the patients. Yeah. I think Dr. Pushpa want to just share a video with us on the iStent procedure with the OCT. Yeah, please. Can we get the video on first? Yeah. All right. While waiting for that, then anybody have any questions? Yes, sir. Please. Yeah.
Thank you, Dr. Leonard. My questions to Dr. Leonard. Dr. Leonard, Yip, this is Ming Mie here. Thank you for very informative talk. I can see you're very good teachers. I have 2 consecutive cases where after implanted the first stent, the second stent, I didn't see my second stent. So I know that I tend to under-implant than over-implant the iStent. So then I asked the sales reps, and then they say I probably have over-implanted it. I'm a little bit puzzled and suspicious. Was it there any second implant in the stand? Then the third case, I called the sales rep in. Then she, with her very own eyes, she didn't see the second stand come out. So my question is, how common for over-implantation cases, the whole implant go into the trabecular meshwork, you don't see the head at all. Is that common? Thanks.
I guess it varies from surgeon to surgeon. The main reason for overimplantation is really one, the patient's factors. For example, if you are doing a very high myope, for example, you have a very high chance of overimplantation in our population. The other frequent cause for overimplantation is overindentation at the point that you deploy the implant, and frequent reason for that is actually that the views, as you start to get striae, you tend to lose the view and you can't really judge the indentation too well, and then that tends to happen. There is a third possible reason for losing an implant, and that's a bit of a rarer cause, and that's in the situation where you have fired your first implant and it has failed to deploy completely, and then you have taken it out and the first implant is still on your trocar, and then you proceed to deploy the first implant which you've previously failed to, and then at the point of shooting it, you can actually accidentally deploy 2 implants during that one shot, and you will only see the second implant on the surface or a little bit deep. But in my hands, overimplantation with iStent W is very, very negligible. I haven't overimplanted one for a long time. But having said that, there are degrees of overimplantation. So, for example, I think if the level of the flange, the surface of the flange is not deeper to the level of the trabecular meshwork, I think that's is still okay. You know, it doesn't have to be that the flange is just abutting the trabecular meshwork surface. I mean, the part nearer to the head is just abutting it. So there are degrees of overimplantation, and there's still some tolerance of overimplantation in the design, I believe so. But in general rule, I think it's much safer to underimplant. If you find that you are doing too many overimplantations, then I would err on the side of underimplantation. Do very light or no indentations and just fire. And if you really find that it is underimplanted, then it's much easier to deal with than an overimplanted implant.
Thank you. Hi everyone. Thank you very much for the opportunity. Hi Dr. Clement, how are you? Actually, this video that I'm going to present is from Sydney Eye Hospital during my fellowship. I was fortunate enough to be trained under great people like Dr. Clement. And this particular video I did with Dr. Ridia Lim. It's just that I want to showcase, we were talking about this overimplantation, underimplantation, and we have this intraoperative OCT in the theater. And that's like a real game changer because it shows you exactly where your eyes stand, and it gives you an overall idea. How is it like implanting, and like how much in the under or over it is. Can we play the video? So this is iStent with OCT. So in this case, we did the cataract surgery first. It's a well-edited video, very short one. So after the cataract surgery, again, we injected the viscoelastic, and then, yeah. So that's a gonio prism. This is my particular favorite one, which just sits well on the eye. And we can see the first one I'm implanted. It's just nice there, and we can see a nice blood reflux coming in. And the second one, we really adjusted the position and going in just nice. And from this video, if you can see, like both looks like sitting well in the TM with a good reflux. But it's just that it's a fortunate day, and then we had the intraoperative OCT in the theater. So we decided, here we are checking, injecting the viscoelastic see whether it's in the right position or not. And I'm quite happy, but just want to see whether it's in the right place or not. So this is the intraoperative OCT, and in the raster lines, we can actually adjust the raster lines and to make sure it's exactly on the place that we want to visualize. So we can see the second one. So the OCT cuts are quite big here, so we made it a bit narrow. And we can just see, visualize there. The iStent is sitting quite nice there. The first one, is it like flushed with the TM, Schlemm's canal, and it's quite nice there. So, and then we move on to the first one that we did. So that's all right. So the second one, yeah, still in the first one, sorry. Yeah, the second one, okay. Yeah, so if you can see, the second one is actually, it's jetting out. It's still in AC, it's not really flushed in. But the interesting part is, we can visualize the aqueous vein. So the iStent, even though it's like, it's still in the AC, but, you can connecting with the aqueous vein, and it's a nice, like just now when you flush, you see the vein is back flushing in the episcleral venous flow. And in the OCT, like in the theater, when you have the OCT, and you can see the actual aqueous vein when you're fortunate enough to have the device and the right placement. So I was quite happy to see that, and thanks to Dr. Clement and all the other consultants at Sydney Eye Hospital who trained me. Thank you.
Thank you so much, Dr. Pushpa, for actually sharing with us. I think the factor of this over-implantation and under, in my little experience, have to do with the first one. If I implanted under, and then when somebody's there, like Jason or Shada said, okay, the second one, just to push more. And that is where you get the over-implantation. And after that, they say, okay, now you have to retract back. What do you mean? So, yeah. The other thing that's interesting in this is actually checking back the flow. Checking back the flow. It depends on, I think, surgeon and surgeon. The expert in the audience can actually share this with as well. I did try, just to show how cool I am, Dr. Leonard, I did try to show, can I inject the leftover vision blue to see there's actually like the episcleral vein? Like Ahmad, like yourself doing it, then I can show to the world. I check the episcleral vein. That is quite difficult for me to do as well. So then I said, okay, then you show us actually just now, just using the BSS, you can actually see that as well. So when we have a flush, at least in my own opinion, that's nice to see there's actually a communication. But do you think it's important for us to check this backflow just to confirm, yeah, we bypass the trabecular meshwork and have communication?
No, I don't think it's important to do that anymore. I think that was just our intellectual curiosity many, many years ago when we were first starting to try and prove to ourselves that we were creating an anastomosis between the anterior chamber and the episcleral venous outflow. Subsequently, I think we trust ourselves more. We trust our techniques more, and so I don't think it's necessary to do everything. Also, there is certain risk with hyperinflating the anterior chamber as well. Sometimes when I've let my fellows do it, what can happen is they become a bit too enthusiastic. They really want to prove it, and then actually we induce a malignant glaucoma at that point of time. So there is a certain amount of risk in doing that as well, from frequent and lots of hyperinflating of the anterior chamber. So I think if you're very comfortable now, you've got your technique pad and you've seen good, blood reflux from your stents after implantation and after removing of the viscoelastic, I think there's no need to go on to do this. That was just intellectual curiosity in the past. Yeah.
Yeah, for me, it's to show how cool I am. God never meant me to be that cool. Okay, that's good. Colin, do you have any take on this?
I I don't do it routinely, do it occasionally just out of curiosity, but I think if you follow all the principles, which is to, visualize the stent, ensure that it's sitting correctly, identify blood reflux, position it close to a collector channel using the landmarks that Dr. Yip described. I think that's as much as you can be asked to do, and will maximise your chance of getting a good outcome. Now, I'll just make one comment about the over-implantation issue. It does happen from time to time, and I agree with Dr. Yip that it's very rare now with the iStent Inject W. And it is common for surgeons to question whether there was only one stent on the injector in the first place. But it's my understanding that as part of the quality control process, each stent is x-rayed prior to leaving the factory to confirm that there are two stents. At the time that you're opening the injector in theatre, it's certain that there are two stents on the injector. So if one disappears, it's from that point onwards, and it wasn't at the time of the delivery of the device to the hospital.
Thank you. Any other questions from the audience? Yes, please. Prof. Mimi, can we have a mic to Prof. Mimi?
Oh, just a request that Pushpa, could you point with a pointer for your OCT images? I think some of us didn't catch where exactly.
Try to play the video again, if you can, and look at that.
The second one was obvious, but not the first one. I was like frantically looking for it.
While we're waiting for that, can you have, just show that, just play. Okay, thank you, Bushra. Okay, all right. Just, okay.
Actually, this is the second implant that we put in. So this is I'll pause the video to show. So it's there. So exactly that area there. So if you watch that space. Oh, this is the second one. So this is the iStent. Actually, partially it's in the Schlemm's canal and partially it's in the AC. But the thing is, this one, we can nicely visualize the aqueous vein. So it's going all the way behind here. So it's forming a nice anastomosis with the episcleral venous system. So even though it's partially in, it's still flowing and it's doing what it's intended to do. But as compared to the first one, it's just a visualization. Again, I think as we discussed with my supervisor, it's nice to have the OCT to show us where is it, but it shouldn't be guiding us. So this is the first one. The first one is nicely flushed with the TM there. And it's nice to see, it's called the trabecular microbypass stent, and this is exactly what it's doing, is bypassing the TM there. Okay. Can you see, Prof? Yeah. Thank you.
Thank you. I think your supervisor is correct. If I want to buy OCT, I need to justify the existence of that OCT. I need to borrow your slide to show to the university. Hey, now you can see there is an iStent there. Now we have to justify the existence of some of our machine there. Now, my next questions to all the experts is this. Usually, when it comes to clinical to me, patient actually comes to me, this is a patient again that have 4 drops maximum and then refusing trabeculectomy or tube. Now, I've been looking into this because I don't want to actually do something that I do not need to do. But is there a role of combination of the so-called mixed procedure? If you look at the American Glaucoma Society, when they look into it, under mix, you can have this TM approach, which is actually iStent and Hydrus. And then you can have viscodilatation as well. Or you can have this goniotomy, and it depends. So I just want to ask the expert now, is there a role that if the patient, and you know our patients sometimes they say, oh, I do not want this surgery, that surgery. But is there a role for us, like, you know, there's a few people who actually in the discussion saying that they're doing the gut for 180, and then they put it in the, you know, they put in the iStent, and we have people who actually try to actually separate things, and sometimes they do the gut for 360. You know, it's so cool to see that light traveling around. So yeah, my questions to Dr. Yip, Dr. Colin, and Dr. Clement, and of course Prof. and the others. Is there a rule that combining this, can it be not as good as the standard trabeculectomy or GDT, but at least there is actually additional reductions in the IOP? I think we go to Dr. Clement first.
Sure. You know, this is an interesting concept because I guess theoretically you would think that if you can access more outflow pathways, you can potentially lower the pressure further. But the problem with the combined approaches that you've described is that they're not evidence-based. So when you are having a discussion with your patient in the clinic about any potential benefit, recovery, what risks and side effects you're exposing them to, we don't have any answers to that.
Right, you. Dr. Yip?
Well, in my practice, I think perhaps if I could just narrow it down, perhaps you're talking about a highly risk-averse patient who is not keen for trabeculectomy, but who could possibly be persuaded for the safest possible option that's available. And I think for such a patient, we have offered to actually put in 4 iStents. So I'm not talking about using the iStent Infinite, which is 3. So, for example, in use cases such as a patient who is on maximum medical therapy, refusing a trabeculectomy, a PrisFlow, or a Zen implant, no matter how safe I tell them my PrisFlows and Zens are, then perhaps they might accept putting in 4 iStents. And I think we had a case series of 12, which we presented as a poster at the European Glaucoma Society 2 years ago. And in general, we found that patients did well, and they were not able to reduce their intraocular pressure, but they were able to reduce up to two of their medications. And conversely, if you continued those medications, then there would be an intraocular pressure reduction. So that's something that I possibly would offer off-label. And of course, now I think we've become very comfortable with putting in inferior iStents as well. So you can put them nasally, you can put them inferiorly, so you can put in a 4 and spread them up over quite a wide area and tap the full set of collector channels there. This is completely off-label, and I only have a poster to back this up at the moment, but definitely I think this could be an option for someone who is risk adverse. Of course, there is a substantial cost involved with opening up 2 injectors at this point in time.
You're correct, Dr. Yip, Leonard. You're very correct. The reason why I asked that is because the external approach might not be the best for ocular surface patient that some of us dealing with after 4 drops of medication. So it's still internal, either the mix or maybe, as you said, the subconjunctival approach where we go Zen. So do you think that if money is not a problem and patients okay with it, that you can combine between this, make the trabecular bypass as well as the subconjunctival, like Zen gel or PrisFlow? Do you think that could be, I mean, at the moment, like Clement said, there's no data to actually support us, but in terms of theoretically, do you think that's a choice that we can entertain?
So far, I think now that we have more experience with doing subconjunctival mix where we do an open approach, for example, the Prisoflos and the Zens, and we do a subconjunctival approach, I think and use high concentrations of mitomycin C, I think we actually can achieve pretty good results. We can reduce 3-4 glaucoma drops and bring medically uncontrolled glaucoma to become controlled. And it hasn't really been necessary to combine them with trabecular mitral bypass. So I haven't gone to combine them at the same sitting because I don't think with the subconjunctival route of outflow being so good, I can't see that that perhaps the trabecular mitral route would add very much more to aqueous outflow and intraocular pressure control. Having said that, of course, we see that with the infinite data that's been done for trabeculectomies, which are failed or failing, and where they have put in the iStent infinites, 3 stents, that has been quite an impressive intraocular pressure medication reduction from using the iStent Infinite. I think in the initial data that was released for the Infinite. So I think it depends. So if something is failing, like the trab is failing, then I think the infinites will help. I think if you're putting it at the same time with something that's just been put in, I'm not so certain that's value in that at the moment.
Thank you. I think the previous study have shown that if, let's say, you do too much as well, there's a plateau of whatever that you do. It doesn't matter whether you do like 180 or 260. I think that's the take-home message as well. I think at the last few minutes, I have to address something, and even though this is actually, sponsored by Glaukos. Anybody have actually experience with hydrus? Anybody? Okay, that's good. Anybody, Leonard or Colin, do you have any experience with hydrus?
Yes, I was using hydrus prior to my iStent. I've put about 80 devices in. And what I would say overall is that I think technically hydrus is more difficult compared to iStent, and particularly with the iStent inject technique. It's much easier to do. And that's really reflected in the way that those devices have been taken up in Australia, and I suspect in other countries. iStent inject in Australia is used both by glaucoma specialists and also other anterior segment surgeons and general ophthalmologists who perform cataract surgery. Whereas hydrus is used almost exclusively by glaucoma surgeons only, because the other guys find it too difficult to use. In terms of outcomes, my impression is that they're very similar. And certainly the data that we have and the other comparison data suggests they're pretty similar. I think the hydrus had a higher rate of PAS and anterior segment inflammation. But that was my impression. So I made a decision that rather than using both in my practice, I was just going to use iStent inject because of ease of use.
Thanks, Colin. Leonard, do you have any take on that?
Yeah, I think I started the iStent inject in 2017 and my hydrus in about 2019. And I would very much agree with Dr. Clement's comments that basically the hydrus is technically much more difficult. And even after much use, sometimes it's very hard to predict its behavior, such as why it dives, for example. And I also agree very much with his remarks. So we have actually audited our data, our hydrus versus iStent data, and we in the midst, we submitted it for publication. We found very much similar to what he said, that actually there is not much difference between the two implants in terms of medication reduction. There's no significant difference in medication reduction or intraocular pressure difference between the two groups, with perhaps just a slight trend towards some advantage for the hydrus, but nothing very much significant for all the trouble. But there is also the problem of a higher rate of blockage of the hydrus in our population. And the that blockage is quite significant because, as you can see, it's quite easy to unblock an iStent and keep it unblocked for long term. But for those hydruses of mine which have got blocked, I can't. Although I can unblock them during the laser, but I can't keep them unblocked for long. After a while, they block up again, and then that's it. Yeah.
Thanks.
So so I think not much to choose, and really it's really so much easier to do an iStent, and so my operating theatre consent is if I really choose to do a hydrus it's a trabecular meshwork bypass surgery, and then if really I fail to do the implant hydrus properly, then I will just click an iStent and then wonder why I even bothered. Yeah.
But yeah, I think it's no-brainer. If you actually first injected the first iStent, that's intimidating. Looking at hydrus is more intimidating. So that's why we let the glaucoma specialist handle with that. I think that's so. Okay, they're worried that we're going to be off. Okay, thank you so much, Leonard, Dr. Yip, Colin, and Dr. Clement for being with us. We appreciate your Saturday evening for this. Thank you so much, and from Malaysia with us, we hope to see you in APGC next week. Okay, thank you.
A pleasure. Good night.
Thank you.
Thank you.
Thank you. Panik dia takut habis. 1 minute. Okay, thank you. Ingat apa benda. So, yes, local expert, we thank you for being here. Nice to be associated with you, and all the questions that I asked, you can see that it's actually very basic. We have a lot of other things to discuss, but I think enough is enough. So we need a 5th iStent user next year for us to discuss that. So I think that's the end of the session, and we have the photo. Is it correct? Yeah. Okay, so we have a photo group taken, yeah? Okay, with a bathing suit or it's just like this? No, okay, the swimming pool. Okay, guide us onto that. Okay, thank you so much, everybody. Thank you for saying. Yeah, Dr. Lu. Yeah. Is there any mic? Yeah, mic over here.
This is for Jason. The question is for Jason. No. I actually had, truthfully, I actually had some experience like Dr. Lee Ming Hui, 2 cases where I doubt that there are two stents in the okay.
You're not alone.
So because normally when we deploy, we can actually see it shooting out, but this one can't. Can I request that, or maybe you can forward the request to Glucose, in future, can they make their injector transparent so that we can actually see the stents inside?
That would be something really good. Yeah, transparent iStent. Yeah.
So that we can actually see there are 2 stents in, because yes, it could be what we call double shoot. That means stacking of the stents. Yeah.
I would say it's a brilliant idea. But to make titanium transparent, probably it's going to be difficult.
It's just the injector, the trocar injector. Yeah, because you need to check that, right? If you can, that would be good. And presbyopic friendly as well. Because many of us presbyopic to begin with. Jason, just pulling your leg. Yeah, then go on.
Right. Okay. So we are at the W Hotel. We chose W Hotel because of the W. Yeah. You haven't tried the W yet. Yeah. So it's Dr. Lee. You haven't tried the W yet. Yeah. So probably for W, we will talk about that later. Yeah. So for W, it's a lot more difficult to get the over-implanted.
And it's a lot cheaper.
Potentially.
Again,
potentially. Yeah, definitely. Yeah.
Okay, we can talk about it during the swimming pool. Yes. Okay. Thank you again, guys. Thank you for being with us, and we're going to go to a photo session. Okay. Thank you.